course is primarily geared toward rehabilitation as an outpatient program, true cardiopulmonary rehabilitation begins in the acute care setting. It is helpful for the respiratory therapist to review their integral role in the patient's transformation from the acute care patient to a more fully recovered individual. Approximately 5 million patients survive a critical care illness in the U.S. each year. A significant number of them experience a life-altering change in their physical, cognitive, and emotional functioning. The factors that contribute to this loss of functioning are acute inflammation, severity of disease, corticosteroid and neuromuscular blocker usage, which are commonly used in the ICU, prolonged immobilization, and long lengths of stay. A cardiopulmonary condition is defined as any disease in which O2 transport fails to meet the body's demand. This may be due to ischemic cardiovascular disease, COPD, post-hoc complications, and complications from hypertension, diabetes, and obesity. Slide 4 describes various cardiopulmonary conditions, their areas of impairment, and the associated clinical findings. For instance, cystic fibrosis, bronchiectasis, asbestosis, and other obstructive and restrictive pulmonary diseases lead to impaired ventilation and gas exchange, decreased aerobic capacity, and airway clearance dysfunction. Clinical findings include cough production greater than 30 milliliters in 24 hours, fever, shortness of breath, hypoxemia, CO2 retention, respiratory acidosis, and decreased FEV1. As respiratory therapists, we are familiar with airway clearance devices and their use in facilitating mobilization of secretions. Our goal is to optimize airway patency, increase ventilation and perfusion matching, promote alveolar expansion, and increase gas exchange. The choice of devices, however, often depend on the patient's condition and ability to correctly use a device. For instance, a vibratory positive expiratory pressure device, i.e. acapella or flutter, is useful for clearing secretions in acute bronchitis, cystic fibrosis, or pneumonia, but it requires the ability of the patient to generate a specific minimum flow rate. Other techniques for airway clearance include postural drainage, percussion, vibration, and cough assist techniques. Precautions for postural drainage include pulmonary edema, hemoptysis, massive obesity, large pleural effusions, and massive ascites. Relative contraindications include increased intracranial pressure, hemodynamically unstable patients, recent esophageal resection or anastomosis, recent spinal fusion or injury, head trauma, diaphragmatic hernia, or recent eye surgery. Precautions for percussion and vibration are uncontrolled bronchospasm, osteoporosis, rib fractures, metastatic cancer to ribs, airway tumors, anxiety, coagulopathy, seizure disorders, or recent pacemaker insertion. Relative contraindications are hemoptysis, untreated tension pneumothorax, low platelet count, unstable hemodynamics, open wounds or burns in the thoracic area, pulmonary embolism, sub-Q emphysema, and recent skin grafts or flaps on the chest. Cough assists are also helpful in clearing secretions. Splinting or huffing may help the post-surgical patient remove secretions when pain is a limiting factor. Breathing strategies, positioning, and ventilatory strategies are indicated for patients who have diaphragmatic weakness or inhibition due to pain, etc. Particularly helpful positions for dyspnea relief are tripoding, where the patient leans forward and the arms are supported, allowing for increased intra-abdominal pressure, which pushes the diaphragm in a lengthened position and thus increases diaphragm contraction. Other positions that may relieve dyspnea are lying in the semi-Fowler position on the left side, leaning over when pushing an object such as a wheelchair while supporting the arms, and leaning against a wall with legs slightly in front. Breathing exercises are generally used in the outpatient rehabilitation setting, but can be incorporated into the acute care setting as well. They include pursed-lip breathing, paced breathing, which means coordinating breathing with the rhythm of an activity, or if the activity has no specific rhythm, then the patient is instructed to breathe in at the beginning of the activity and out during the activity, inspiratory hold to aid in airway clearance and improve ventilation to poorly ventilated regions, and stack breathing to maximize inspiratory volume. Diaphragmatic control breathing may be used to manage dyspnea, reduce atelectasis, and increase oxygenation. Training the patient to expand the abdomen and minimize upper rib cage motion during inspiration are hallmarks of this breathing pattern. The patient may be instructed to sniff and breathe into the therapist's hands while they are placed on the abdomen and then scooped up under the anterior thorax. Upper chest inhibiting technique allows the patient to recruit the diaphragm during inspiration. Slight pressure is applied to the upper chest during inspiration to discourage accessory muscle use and encourage engagement of the diaphragm. Lastly, inspiratory muscle training may aid patients with decreased muscle strength in the diaphragm and intercostal muscles. Indications include patients with decreased chest expansion, decreased breath sounds, shortness of breath, irregular breathing patterns, bradypnea, and decreased tidal volume. Resistive trainers and incentive spirometers are two devices to aid in this effort.